my name's Shrek, and today I'll be presenting to you on the mixed cranial nerves and the clinical consequences of their varied palsies. So firstly, what is a mixed cranial nerve? So a mixed cranial nerve is a cranial nerve that has both sensory and motor innervation. So these are cranial nerves 5, 7, 9 and 10. Some textbooks consider cranial nerve 3, the oculomotor nerve, to be a mixed cranial nerve because it has some small sensory innervation, but mainly only has a motor and autonomic. So moving to that nerve, it supplies the muscles for eye and eyelid movement, which are the ocular and extraocular muscles which we've just learnt about. You can read them at your own leisure. It has parasympathetic innervation to the pupil, so it constricts to vary the amount of light entering the pupil, as well as the ciliary muscle to make the lens more spherical and focus on short-range vision. Now, palsy to this nerve can be caused by many things: high intracranial pressure, aneurysm, cavernous sinus infections, as well as diabetes. Now, mainly the clinical signs are ptosis, which is drooping of the eyelid, mydriasis, which is a constant dilated pupil, as well as the eyeball being positioned inferior laterally on the affected side, so the ipsilateral side. So I've got this video, but it usually... No?
It won't work because you're recording.
Yeah.
Let's just carry on and we'll see what we can do.
Okay, I have a few of these.
Is that your video?
Yeah.
It's probably not been uploaded, so it's separate to the PowerPoint, I guess.
Yeah, I think it is, yeah.
No, it's in the PowerPoint.
Yeah, I know, but that's not running the PowerPoint directly, that's just running off the Connect server.
Can I run the PowerPoint directly?
Have a word with Dr. Thomson how he wants to do it.
Okay.
Yeah. Yeah, I'll do that. Yeah. I got it. Yep. So this video usually lags.
Sorry.
Yeah, since this video usually lags, but what I'm trying to show you is ptosis, which is drooping of the eyelid, and also on the ipsilateral side, this eyeball doesn't follow movement of this, so this is looking superiorly, whereas this isn't, as well as when you shine a light on this side, which should get to it soon. Come on, yeah. Here, the pupil does not constrict. I can appreciate this is a bit difficult to see. The next videos will be a lot better. So the trigeminal nerve, this has 3 branches, all of which have sensory innervation. The mandibular has sensory and motor innervation, so we'll consider that. The green area of this face has sensory innervation from the mandibular nerve. So the mandibular nerve, its motor innervation is to the muscles of mastication, which open and close the mouth. You can test for this by applying cotton wool on the sensory areas I showed previously. You can test the motor innervation by palpating for the masseter muscle and the temporalis muscle when you have a clenched mouth. You can also test for the corneal reflex. Now, it's important to consider that a reflex always includes 2 nerves, an afferent portion and an efferent portion. The efferent portion of the corneal reflex is formed by the facial nerve. Now, an absence of this reflex can give you an increased risk of infection for obvious reasons that we've just considered. So causes, you'll start to see a pattern. Things like infarction, infection, neurological conditions, as well as tumour. I've listed them for you so you can read them. So clinical signs, they're heavily dependent on where the lesion occurs. So in upper motor neuron lesion, you get reduced sensation or dysesthesia, which is abnormal sensation, as well as weakness of jaw clenching. In a lower motor neuron lesion, the jaw deviates to the weaker side when the mouth is opened, as well as abnormal twitching, which is fasciculation of the temporalis and masseter muscles. So this will work perfectly. Yep, so the temporalis muscle, there's a depression there, so that muscle is very weak. When the mouth is opened, it deviates clearly to the weaker side. And the corneal reflex on the unaffected side is most definitely present, whereas the corneal reflex on the affected side is most definitely absent. So now to the facial nerve. This innervates muscles for facial expression as well as muscles derived from the second pharyngeal arch. Now it has sensory innervation around the ear as well as special sensory function for taste. It has parasympathetic innervation to mucous membranes and glands of the nose and mouth. Now to test for this, you can ask the patient to raise their eyebrows, ask them to close their eyes against resistance, puff out their cheeks and make a broad smile or reveal their teeth if they have any. So all these babies have demonstrated such prowess. So the facial nerve, its palsy depends, its clinical signs depend on where the lesion occurs, and the causes for which, again similar, cerebrovascular disease, infection, trauma, neurological, neoplastic. I've listed all the conditions there. So the clinical signs, as I said, are dependent on where the lesion occurs. Now, in an upper motor neuron lesion, you get weakness of the lower contralateral side of the face, which is the opposite side to the lesion. Whereas in a lower motor neuron lesion, you get upper and lower ipsilateral weakness of the side of the face. So that's the same side. You also get sensory damage in the form of reduced salivation, loss of taste, increased sensitivity to certain frequencies of sound, which is hyperacusis, as well as reduced lacrimal fluid production. Bell's palsy, which is a common facial nerve paralysis, is of unknown cause. So this video again will work fine. So as you can see, this eyebrow can be raised adequately, whereas this can't. When the patient blinks, this blink is much more powerful than this. And also the killer diagnosis feature, only the unaffected side of the face can smile. So moving on to the glossopharyngeal nerve, this is involved in swallowing. So it has sensory functions around the tongue and pharynx, as well as some taste function. You can test for this by asking the patient to swallow water, as well as the gag reflex, the efferent portion of which is formed by the vagus nerve. So the causes, again, I've listed them there. Clinical signs of damage to this nerve would be loss of taste, mainly bitter and sour, impaired swallowing, and coughing mainly because of lesion to cranial nerve 10, as well as loss of sensation to the posterior third of the tongue. Now again, it's important to note in causes that isolated lesion of cranial nerve 9 is rare. Usually it's palsied with cranial nerve 10, the vagus nerve, and usually it's bilateral as well. So moving on to the vagus nerve, the final nerve, this supplies the muscles of the pharynx, soft palate, palatoglossus, and muscles of the larynx. So it has sensory innervation somatically to the skin around the external acoustic meatus and viscerally to the laryngopharynx, pharynx, heart and GI tract. It has a small role in taste as well as parasympathetic functions to the smooth muscle of the bronchi, GI tract, and obviously regulating heart rhythm, as we know. So palsies, again, it can be caused by similar things to the glossopharyngeal nerve, and again unilateral lesions are rare. An important branch of the left recurrent of the vagus nerve is the left recurrent laryngeal nerve, and this can be damaged by aortic aneurysm or bronchial carcinoma, as we know. Now, damage to the vagus nerve can give you palatal weakness and reduced palatal elevation, and hence you'd get choking and nasal regurgitation, as well as failure of the vocal cords. Damage to the left recurrent laryngeal nerve would give you a bovine cough, like that, and also a hoarseness of voice, as we know. You can test for this with the gag reflex. Again, it's important to note that this is absent in a healthy proportion of adults, as well as testing for speech and testing for deviation of the uvula, which you can see here is clearly to the patient's right. Thank you for listening. If you have any questions, please ask.
Okay, so this presentation is unlikely to be on the recording because we operated on a different video. It could be recorded. I can't guarantee. This is a shame because the video is like Ellen Sutherland.
Yeah. Okay, so I think you're really confident. That's really good, and it showed that you knew what's going on. I think the rest of it you did it all on your own as well. Like most people had to get a lot more to learn. It was well structured, so you went through each nerve and then you did functions, causes, signs, then the video, and you knew what was going on in the video, so you could put exactly where it was. And when what they showed, you knew it was like being shown, so you could explain it well. And I thought that made it really interesting and understandable.
Excellent. Chloe Jane Warner? Yeah.
So again, it was really good, but sometimes when you're explaining things, you have to point to them on yourselves, but then not say to everybody else that you were pointing to them, so people were looking at that screen and couldn't see what you were doing, which would have been useful to them, I suppose. And as well, quite a few times you say, oh, you can read these, but then by the time I'd got halfway down, the slide had skipped. But I know obviously you two are trying to straight, so you have to be quick. But yeah, and then another thing just about the timing, sometimes the pauses, you could have, like, on quite a few of them we went into a lot of detail, but then I think on one or two, it was just some that maybe you could have mentioned because they were a little bit unusual, that I had no idea what they were, because other people maybe didn't as well. Other than that, it was really good.
Okay. Any questions from the class? Yeah.
What's the difference between upper and lower motor neuron?
So an upper motor neuron lesion would be upstream of the nerve, and the lower motor neuron lesion would be further downstream of the nerve. So that's where the blockage would occur.
In relation to the middle of the nerve?
Yeah, or just in relation to the nerve itself.
Yeah, I don't know from what you said about the pauses. I think on the Glossopharyngeal Nerve palsy,
Yeah.
there was something called Laryngeal phobia.
This?
That one there,
Yeah.
yeah. What is that? How does it cause
So so if I had an X-ray, I could show you quite clearly. But the brainstem is a cone-like shape, and syringobulbia is when you get a tubular, a fluid-filled cyst within that brainstem, which compresses the brainstem and hence palsies the nerve which arise from it, i.e. the glossopharyngeal nerve and the vagus nerve. So it's just like a tube. It's like a cyst, like a swelling in a tubular shape form in the middle of the brainstem.
Any other questions?
Could you repeat that about the upper and lower?
So an upper motor neuron lesion, what in regards to any nerve in particular or in general? What do you want to know?
Just in general.
In general, so an upper motor neuron lesion is upstream of the nerve, so it can be in the brain, the cerebral cortex of which the nerve arises. So if that cerebral cortex is damaged, that would be known as an upper motor neuron lesion, whereas a lower motor neuron lesion is the nerve itself. If the nerve itself, where before it attaches to the muscles, it innervates. If a lesion occurs there, that's a lower motor neuron lesion. Is that okay? Okay.
Yeah, it's a slightly advanced concept because we're doing that in third year. But effectively, any cranial nerve, we're talking about cranial nerve motor nuclei, if you remember earlier. If you damage the nerve anyway from its cranial source, like where the nucleus is, all the way down to the periphery, that would give you a lower motor neuron type lesion. So that is effectively damaging the motor neuron to the muscle, if you like. However, that nerve itself is under the control of the brain. So if you damage the brain and the nerve is intact, you end up with what's called an upper motor neuron lesion. And that tends to be contracted on the other side. But we'll do that next year. And also the syringobulbar palsies, all those things, we'll do those next year in the third year. So we'll come across this. Any other questions? Go downstairs. Right. Thank you very much. I thought the presentations were excellent, but more importantly, I think I'd like the critiques who were able to sometimes criticize, which is a major part of your skills. You've got to be able to criticize. It doesn't mean when you criticize something is bad. It just means you are actually attentive. You can always improve on stuff. So